Well, good evening, everybody, and a very warm welcome to our annual members meeting. I do wish I could see you all out there, rather than greeting you in this detached way this evening. But it is an annual meeting, and as with all annual meetings, I'm going to start with the comment I make every year. This is a punctuation point. It marks the end of a period, of a year, and it's an opportunity to look back and reflect on that year gone by. But for me, it's even more important we take the opportunity to look forward, to look at the aspirations and ambitions of the year to come. We will do both of those tonight, through Craig with his chief executive report, through Helen Beck and the storm we faced, and what a year it's been. What a storm. I mean, after the storm, really apt title for this evening. It just about sums up everything that this year has been. And what's worse, it's still raining. And we really must remember that it is still raining. It's not over yet. Tonight gives us the opportunity to look back on some real people's experience. People who received care, people who gave care. And had that experience of living at the very heart of the hurricane. However, as I said, we will look to the future. We've got a lot to learn from the last year, a huge amount, not just from COVID, but from the recognition we have as an organisation about the things we need to learn, about the cultural changes we need to make. And there is a lot of exciting things happen as we move into the next year. One of the things I can't let the introduction go without is saying thank you. There are so many people to thank. I can't thank them all. I do want to pay tribute above all to our staff. I've always thought we had the most amazing staff, but they've been more than amazing this year. The care and dedication they've given to our patients, and we'll hear more about that as we move through, is incredible. I really want to thank them on behalf of the board from the bottom of my heart. And I do just briefly want to allude, and I know Craig will later, to Steve Dunn. I want to thank him for the amazing focus, energy, passion that he brought to us. He's achieved amazing things during his time at West Suffolk. And he's left us with a legacy, and I've said this before, a legacy that means that we have to continue to be ambitious, to seek to achieve, and that ability to punch above our weight, which sometimes people regard us as a small district general hospital. We are more than that. We can be more than that. And I want to make sure that we continue to do that. But we wish Steve well in all his future ventures. And to move towards the first of our presentations this evening, I want to mention our governors. They're such an important conduit into our community. And they've had a desperately challenging year trying to do their role. Their role of interacting with the community has been almost impossible to do. They've provided us with support, with constructive criticism, and true enthusiasm and commitment to the trust. I thank them particularly. And I thank Liz Steele, particularly as lead governor, who I think has had an incredibly challenging task of playing that role through what must be one of the most challenging years the NHS has ever faced. And at that point, I'm going to stop and I'm going to hand over to Liz Steele to talk a little bit about what it's been like to be a governor during this year. So over to you, Liz, and thank you.
Thank you, Sheila. I'm just going to give a little bit of a background. On January the 31st, 2020, I was sitting in a board meeting at the hospital in the education centre. As I sat listening, my phone pinged a news alert that said that the first COVID COVID-19 case had been confirmed. I wrote a scribbled note to the chair, Sheila, alerting her to this and asking, are we ready and can we cope with this if we are to get any cases? Little did any of us know just what would be in store for the hospital, our country and the world. As we moved into February, it was becoming clear just how very challenging and catastrophic this would be to each and every one of us. Then lockdown. What would this mean to governors who'd been used to meeting at the hospital in person and being able to chat face to face? We were instantly not allowed to come into the hospital, and it was clear so many of the roles that we'd been used to carrying out now were not going to be the same. Thankfully, the hospital IT team soon came up with solutions. We were introduced to Teams. In the beginning, it was a novelty, everyone waving at the screen or learning how to put up a symbolic hand by the click of the mouse. I was introduced to the need to chair meetings by having my deputy watching for those yellow images and texting me if I'd missed someone. We all became adept at multitasking, having not just one screen, but possibly two or even three, so that we could view the meeting on one, have the papers on another, and in my case, text with a third. It was not easy ensuring that everyone had the opportunity to contribute to the meetings, and the absence of the pre-meeting coffee and chat questions were not picked up. In order to help with this problem, we brought more into focus the Governor Question email box facility. Governors were encouraged to send their questions in, and they would be answered and shared once a month with all governors. The governor elections were looming, and we were going to have a large number of governors retire as they'd served for their 3 times 3-year term of office. The process of the elections was straightforward, as this could be done via email and post. What would prove to be far more challenging would be the get-together that new governors usually experience, and to date, we have not met in this way. One could say that this new world of technology was easier, and all we needed to do was turn our computers on in our homes a couple of minutes before the meeting, and without leaving our homes, we were there. It is good for that, but it has created the environment of not being able to share conversations offline that often facilitate answers to many concerns. Our statutory committees took place in the same way, and for some of us, we've had to carry out interviews online also. This has not been easy, as part of the interviewing is to see the candidates. Thankfully, we've now been able to return to face-to-face interviews, and for the candidates and for those interviewing, this has proved to be a far more successful path. This has been a very busy time at the hospital, not only with the patient numbers, but also with the issues of ageing buildings, staffing, and the sheer pressure of working through these unprecedented times. One of the important parts of the governor's year is the regular training. We want to be on top of all the new requirements and guidelines. We work closely with our NEDs, and so we took part in joint training with them, our teams. Very shortly, we'll be undergoing another training day, but thankfully in a large venue so that we can be together, but of course with social distancing adhered to. For our new governors especially, it will be our opportunity to get to know each other a little better. One of the important roles of the governors is the annual appraisals of the non-executive directors and chair. This process took place just after the appointment of the governors, so for them this was virtually impossible, having only seen our NEDs on screen. However, this task was successfully carried out. What is our focus for the future? The role of the governor is not operational. It is to be satisfied that the Unitary Board is carrying out its role successfully. We're particularly mindful of the needs of the patients and staff. In the past, pre-COVID, we were able to carry out quality walkabouts, environmental observations and department observations. With the onset of the pandemic, these ceased instantly, leaving governors in the dark and concerned about what was happening in the hospital. I'm pleased to say that following several meetings with the executive lead nurse and others, we have started this process again under a new banner, the first 15 steps. This is a way of governors, NEDs and other clinical staff being the eyes and ears when walking into different wards and departments. We are critical friends, focusing on the needs of our patients and our relatives and not forgetting our staff. We're involved as observers and contributors to the future system, which is the name for the work programme for our new hospital. We've been lucky enough to walk the site. This has given us a focus for a very important future role we have. We've been observers and contributors to engagement meetings held for each department so that we can see their vision for the future and contribute our thoughts as patients and governors. Although there is a hope for us to get back to normal, our world will never be the same. As governors, we will embrace technology when it is right to do so, but we will mix it with the important need to support each other and our public face to face. We want to restart and expand our engagement opportunities, and in particular look at encouraging our young people to know that they have a place in the future. They may not think they need us now, but they will do, or they may know someone near to them that needs us now. We need to look at the integrated care system and to support its implementation so that the pathways of our patients run smoothly. When we all work together for all, the outcome is the best we can have. We also work with our colleges and schools to encourage the professional journey of those who aspire to work in the health service and encourage others to consider to do. Thank you for listening. And now I'm delighted to introduce you to Craig Black. Craig is our new interim chief executive and will be giving some insights into the year the trust has had. Over to you, Craig.
Liz, thank you very much. And I hope everyone will agree that that was a fascinating insight into the role of the governors and the lead governor in particular, and just describing how valuable that external perspective is to the rest of us who work in the organisation. Liz, as you were describing the number of screens that you were faced with, I was looking around. I'm surrounded by 5 screens, which I think probably reflects a level of ambition rather than my ability to realistically multitask to that extent. You described a challenging year, and this has indeed been the most challenging year that many of us can have ever experienced. And I'll go through some of the aspects of the last year before I'll introduce you to some personal reflections coming at the last year from various different angles. But Sheila at the start mentioned Steve, and it would be remiss of me not to talk about Steve. The reason I am here is because Steve has recently departed. Steve worked tirelessly for the community, and I genuinely don't think that there is a more visible chief executive anywhere in the NHS. And we all owe Steve a huge debt of thanks, so thank you, Steve. As I said, this has been a year like no other. Sometimes when we're talking about the health service, we focus on buildings and big pieces of equipment as the things that are important in delivering healthcare. But the reality is that healthcare is delivered by people. There are 5,000 staff that work for the West Suffolk NHS Foundation Trust, and over the last year they've shown enormous courage, dedication, right the way through the pandemic, looking after the sickest people in our community. And time again, they have gone above and beyond what it's reasonable for us to expect them to do. I want to extend my personal thanks to all people who work for the Foundation Trust, And thank you for your hard work in what has not only been a hard year in the organisation, but often a hard year outside of it as well. The next slide covers some of the numbers, and I know some people, I'm an accountant by background, so numbers is the way I understand things. The way we've delivered healthcare has had to change, and you can see the evidence of some of that on the slide. We have had to communicate in a way that's been very different. And right in the centre of that screen, you can see that there have been over 40,000 calls made to our clinical helpline. A different way of communicating, but one that's been essential in keeping people in touch with patients in hospital because they haven't been able to visit in the way they would have done previously. There's also a mention of vaccination, and I will come back to that later. But vaccination is the way we get through this, and this is an opportunity to encourage everybody that when you do get the opportunity, please get vaccinated. It's been a huge team effort, not only within the Trust, but also across our partner organisations. The pandemic has highlighted that the way in which we work in the health service is heavily influenced by the way other organisations in other parts of the health and care sector work. We have what we call an alliance approach in West Suffolk, where all elements of the public sector and indeed the voluntary sector come together to agree the best way of working. We have, over the past year, joined up care more than it has ever been before, providing care closer to home to make the best use of our resources and indeed improve patient experience. Our amazing community teams mean that more and more people are being cared for closer to where they live, allowing them greater independence and a better quality of life. But before the pandemic, it had been a turbulent time for the Trust. In January of last year, we had a CQC inspection, and that CQC inspection found that we require improvement. It raised various issues that we have been tackling, so those issues such as managing infection risk, managing medicines, record keeping, and in particular staff not always feeling able to raise their concerns. So despite the pandemic, we've been working hard to address those concerns, and all of us are determined to improve. In addition, in February of last year, following events arising from a letter sent in late 2018 to the relative of a patient who had died at the Trust, an external review was commissioned by our regulators at NHS Improvement. That review is considering the appropriateness and impact of actions taken by the Trust. The report from the review will produce advice to the organisations, and we're absolutely committed to acting on that advice and improving. Notwithstanding that, I would like to take the opportunity to state publicly that we as an organisation got things wrong, and for that we are genuinely sorry. We absolutely want staff to feel confident in raising concerns, and we're taking action to improve the culture and develop one that is kind, supportive and compassionate. Staff being able to share their concerns is a key part of delivering a safe service to our patients. It's absolutely something we are committed to. And when the report is published, and we think that will be in October, we will look at the findings. We welcome the advice that we will be provided, and we're absolutely committed to acting on any recommendations that are made. So what have we been doing to improve over the last 12 months? We have been listening. So the NHS staff survey had a response from around 2,000 of our staff, so about 40%. Some of our scores, most of our scores did go down, although many are still well above the national average. The areas where our scores reduced were in themes such as health and well-being, feeling safe to raise concerns, as I mentioned earlier, and feeling supported and valued by their line managers. Through our people plan and our What Matters to You survey, we're looking at ways we can improve on those issues. We've raised the profile of our Freedom to Speak Up Guardians as part of a drive to help staff raise any concerns that matter to them. But as well as listening, it's important that we take action. So we are taking action to develop a more open and transparent culture. We are supporting staff conversations, reviewing our HR policies, and pursuing the Better Working Lives initiative. We're working through a robust action plan related to the recommendations made in the CQC report. We're early adopters of a new National Patient Safety Incident Response Framework, which will improve the way we respond to and investigate patient concerns. And we're fully cooperating with the external review so that we can take on any additional learnings that will arise from that. But against that background, we're seeing an unprecedented increase in demand for our services. Across this year so far, we've seen a 10% increase in attendances at the hospital. Over the summer, we've experienced some of our busiest ever days in our emergency department. So demand that normally happens in winter, we've been seeing over summer. We've also had to pause elective care during the height of the pandemic, and that means there's a backlog of patients that has built up, and we need to address that. So we need to innovate in terms of the way that we deal with that increase in demand, and later Helen will talk you through some of the measures that we are taking, such as further joining up acute and community care, what we are doing about that backlog of elective work, and how we're offering a mix of in-person appointments, online consultations, and self-driven recovery techniques, but making sure that that is responsive to the needs of the patient. We're also supporting our staff to deliver those services. We have rolled out and we continue to improve some of our digital solutions like Medically and eCare. We've also invested significantly in IT across our community staff. We have, as far as possible, equipped our staff with the necessary equipment so that people can, where they are able to, work from home. In the hospital and across the community, we are providing free hot drinks. In the hospital, we're providing hot food at night that's free, and we've provided free car parking throughout the pandemic. We're also changing the facilities, and at the Bury St Edmunds site, we've expanded our emergency department to help treat patients with infectious diseases. We built and opened a new ward, G10, which increases our capacity. And at the community hospital in Newmarket, we've also increased the number of beds. But we're also planning for the future. And as part of those plans, which look at the way in which we're going to deliver healthcare over the next 30, 40, 50 years in the west of Suffolk, we need you to get involved. You will see in the chat a website link, so please click on that and get involved. But while we wait for a new hospital, we need to keep our existing hospital buildings as safe as possible. Many of you will have seen that on Look East in August, we described some of the issues that we and other similarly designed hospitals are facing and what we're having to do in order to combat that. I think the thing that can be underestimated is the significant challenge and burden that places on staff, but also patients, in moving around the hospital to facilitate the work that's going on. But that level of uncertainty is dealing with that is a testament to the way our staff have risen to that challenge. I've mentioned some of the things that we're doing to look after staff. We have put staff health and well-being centre stage. On this slide, you can see the staff psychology service that we've established over the last year or 18 months. And in the middle, Emily Baker, who provides outstanding leadership to that team. As well as that, we've got other support for staff, including free gym membership, welfare packs, calm spaces supported by our My Wish charity. And we've also been running wellbeing weeks called Love Yourself, providing free events to staff. We've vaccinated over 16,000 health and care staff across the west of Suffolk, and we're looking forward to the next round of both booster jabs and flu vaccines. So there is some formal business we need to go into in this annual members meeting, but before we do that, I want to both thank all those across the community for their support over the last 12 to 18 months, but also to thank the staff that have delivered that service. I'm hugely proud to work for West Suffolk Foundation Trust, and look forward to the things that we will do together over the next few years. As part of the annual members meeting, we do need to offer you the chance to see our annual report and accounts, and you can download copies of those documents from our website. But now I'd like to play a video that our communication team have created, which offers some insight into the work of the Trust.
These are the hands that touch us first. Feel your head, find the pulse, and make your bed. These are the hands that tap your back, test the skin, hold your arm. Will the bin, change the bulb, fix the drip, pour the jug, replace your hip. These are the hands that fill the bar, mop the floor, flip the switch, soothe the sore, burn the swabs, give us a jab, throw out And these are the hands that stop the leaks, empty the pan, wipe the pipes, carry the can, clamp the veins, make the cast, log the dose, and touch us last.
A huge thanks to our communications team for putting that video together. Now I'd like to introduce the chair of our panel event, Emma Birchley. Emma's a familiar face on TV as a news correspondent for Sky News. In a career spanning 2 decades, I'm hoping you don't mind me mentioning time, Emma, but Emma's covered major breaking stories from riots to air crashes. 20 years as a national news correspondent has also meant interviewing everyone from prime ministers to Hollywood stars. Tonight, Emma is going to share after the storm, restoration and recovery following COVID-19. We'll focus on how we are planning for the future, how we're dealing with unprecedented levels of demand, and finding new ways of working and innovating to improve our patient care. At the end of the discussion, there'll be an opportunity to ask questions, and we'll open the floor to discussion. So now I'll hand over to Emma.
People to hear from now. And first off, Derek Lambert. Now, he works in the Trust's IT department, but at the beginning of the year, he found himself in a position where he discovered what it was like not to be just behind the scenes at the hospital, but when he needed the care of his colleagues on the front line. He contracted COVID-19 in January, and he spent 10 weeks in hospital. Well, thankfully now he is on the mend, he's making a good recovery, and he joins us to tell us all about his experiences since then. Over to you, Derek.
Thank you, Emma. Let me begin. Hello, my name is Derek Lambert and I work in the hospital IT department. I also have some clinical experience as an ex-paramedic. In December 2020, I booked the whole of Christmas off as annual leave. Wasn't due back to work until the 4th of January 2021. I remember Christmas Day and I remember Boxing Day, but I don't remember much after that. I know that I attended the COVID hospital, but I have no idea how I drove here and got home again. Apparently on the 5th of January, I dialed 999 and requested an ambulance. They refused to send one and suggested that I call 111, which I did. Fortunately, they contacted the ambulance service and insisted that an ambulance be sent to me. I can recall none of this, but I know I was taken to hospital by ambulance. I'd like to set the scene for you by reading to you a synopsis from my critical care diary. You developed symptoms of COVID on the 30th of December and were admitted to the West Suffolk Hospital on the 5th of January. You were admitted to critical care on the 8th of January with increasing shortness of breath. You were given high flow oxygen through your nostrils and were on high rates of oxygen. You were then helped onto NIV, which is non-invasive ventilation. This is a tight-fitting mask connected to a machine that exerts extra pressure to support the bases of your lungs. You found this difficult to tolerate as it can be very claustrophobic. As the night progressed, you became more agitated, most likely as a result of poor oxygenation. You received medication to help you feel more settled. You were also encouraged to lie on your front, as this has been found to help reduce the amount of oxygen needed in COVID patients. This initially made your breathing more comfortable. However, by the 9th, we were on 100% oxygen with low saturations of oxygen, and you needed to be put on a ventilator in the best interest for your survival. As I'm sure you can imagine, I was very unwell. I spent a total of 10 weeks in hospital, 6 weeks in critical care on a ventilator, and 4 weeks on ward G9. I would like to say that I'm in awe of what the staff and doctors on critical care did for me. You know, because of the drugs you are on, you tend not to be aware of everything that happens to you. The medication gave me strange dreams and memories that I'm sure have no resemblance to actual events, so I'm going to steer clear of those. At something like the halfway mark of my 6-week stay in critical care, in hospital terms, I became very poorly. That's a euphemism for being close to death. That morning, my stepdaughter was allowed to visit me for a few hours and hold my hand and talk to me. I wish I could remember that, but I don't. But the fantastic staff doctors pulled me through, and a few weeks later, I was transferred to the ward. On leaving critical care, I spent small amounts of time on a couple of wards, but ended up on G9, where the fantastic care that I received on critical care was continued. I experienced great kindness as well as professionalism. And I'm not just talking about the nursing staff or doctors, but also people like the physiotherapists, OTs and dietitians. They all helped me on my road to recovery. I'd lost an awful lot of body mass, so it was difficult just to stand up at first. But within a couple of weeks, I was doing laps around the bay with a walking frame. On the 4th of March, after 4 weeks on the ward, I was discharged home, which, considering how ill I'd been, was quite remarkable. And it was all due to the care that I'd received from start to finish. I cannot finish this section without mentioning the send-off I got when leaving the hospital, when all my colleagues were waiting outside the hospital, cheering and clapping. It was the most wonderful and moving experience. I'm pleased to say that I returned to full-time work on the 1st of June, and that my managers and colleagues have been very supportive of me and are still very protective of me even to this day. My aftercare has been nothing short of remarkable. I received physio at home for a number of weeks, and I've had outpatient appointments with the respiratory department, the critical care aftercare sister, and the critical care clinic. I was also invited to join the Physio Fit Club, which I did and thoroughly enjoyed it. Uniquely, I have a very privileged position, which most patients don't have. I have been able to return to the departments and wards that cared for me and meet some of the staff and doctors, and to thank them for their care and kindness and for saving my life. Thank you.
Thank you so much, Derek. I don't think anyone listening could fail to be moved by such powerful words. And obviously, it was really heartwarming to hear your response to the way you were treated in hospital, and also afterwards. Must have been incredibly traumatic for you and also for your family. So great to hear you're back with them and you're back at work. Now, next we move on to Kate Foxwell. She is a community matron on the front line, and along with her colleagues, does amazing work providing the best possible quality of life for patients, care for people in their own homes, and do all they can to prevent people ending up having to be admitted to hospital. Kate's going to tell us about the support provided for patients throughout the pandemic and how the services that they offer have been adapted and how that's still being carried on now. Over to you, Kate.
Thanks, Emma. You've bigged me up. As you can imagine, when COVID-19 and lockdown hit, many of our patients were extremely vulnerable and nervous. It was vital that we provided reassurance to patients as well as reducing the risk of transmission on the virus. Our priority was to patients always, and we never stopped putting them first. Each patient needed a comprehensive bespoke care plan, as everyone's reaction to COVID-19 was different, but there was a clear goal to manage patient need while reducing risks and face-to-face contact. Luckily in Newmarket, we already have been testing a virtual ward situation, so we took some of the elements from this and adapted them to manage patients in the new environment. The most important element was to ensure that patients knew that they were not going to be abandoned and that their needs would still be addressed. We collaborated across the teams and organisations. With a reduced workforce and high risk of transmission of infection, the community health teams needed to be innovative about how they supported patients. There was a much more generic way of working needed. For example, therapists were trained to do simple dressings and observations so that one contact could complete all of the interventions, reducing the contact risk. However, this needed to go beyond healthcare. So we looked at care packages and where contacts overlapped. So for example, if a district nurse was visiting for insulin at tea time, they would be able to prepare the meal for that person, thus the care visit was not needed. Luckily in Newmarket, we already had someone as part of the virtual ward coordinating care visits, and she was able to bring all the systems together to increase the communication and ensure that there was no duplication of contacts. This has built up some excellent relationships across the different services, which have continued to this day. We also ran virtual wards. So we have what's called the enhanced service, also known as a virtual ward, which is a test and learn project in Newmarket and was running when COVID came along. It was a responsive service to reduce admission and support early discharge. As part of the service, there was a coordinator with access to computer systems of the hospital, community and social care, and therefore she was able to communicate and coordinate across the systems and ensure that there were no duplicate visits and reducing infection risk for patients. She ran Teams meetings daily or as needed to discuss patients and ensured that the right professional was visiting and improved the communications. The integrated neighbourhood team coordinator was also able to obtain urgent social care packages for patients and provide overnight sits or visits if needed. She had key safes that could be instantly fitted and also arranged for urgent equipment. Patients were seen by the community matron as in a responsive manner. As well as nurses, therapists and the volunteer sector. Patients had access to the telehealth wearable device if needed. At discharge, the patient was given a shared care and support plan and this enhanced communication between the community and other healthcare sections, especially the ambulance service, to try and prevent unnecessary admission in the future. So, as I say, we manage patients remotely. So the picture on the screen is what we call the telehealth kit, and it's by a company called Current Health. These were small devices worn by the patient to manage vital signs and could be to determine any deterioration or help manage medication titration remotely. So I can see a dashboard on my phone, and the ink coordinator can also monitor from her computer. We have these devices set up on people coming out of hospital post-infection if needed, and also for those who are nervous about their long-term conditions. So I have a patient who has COPD and heart failure, and he wears his device most days. It helps him to take control of his own health, so he can check his BP, and also, when we have access to them, measure his own weight and titrate his diuretics up and down as needed. It's boosted his confidence and reduced face-to-face visits to a minimum. So I only need to visit if there is a discrepancy in his data, or if there's an indication that he needs his chest examined. So what's next? So in light of all the work that happened during COVID, we now have an enhanced service in most of the areas across West Suffolk, with an ink coordinator managing multidisciplinary meetings and supporting most of the vulnerable patients in a holistic, responsive and organised way to prevent hospital admissions or enable early discharge. This can go some way to addressing the increased need in the community of social isolation and physical deconditioning that's been caused by lockdown, whilst increasing communication between the local services for the best interests of patients. Patients have access to a 24-hour service and organised input from nursing, therapy, medics, volunteers, social care, mental health and the emergency teams, amongst others. Professionals need to be able to identify patients who need an enhanced service and have a clear route into this. Post-COVID-19, it can be said that a responsive, comprehensive, collaborative and individualised care is the only way forward to managing the increased need in community. Thank you.
That's brilliant, Kate. Thank you so much. I think what's clear is how quickly you adapted and how much pressure you have obviously been under during the pandemic. It's also good to hear you describe having an enhanced service now as a result. So that's all positive stuff. Next, I'm going to introduce Paul Molyneux, Dr. Paul Molyneux, who is a consultant neurologist at the Trust. He's been in that role for 18 years. He's now the Trust's interim medical director and provides a clinical voice on the board as well, and shares responsibility with the chief nurse for the delivery of high quality care, and that means creating the best possible environment for doctors to deliver the best care that they can. Over to you, Paul.
Thank you so much for the kind introduction, and thank you for the opportunity to share some of the experiences of our doctors through COVID with you this evening. I'm presenting this really on behalf of Dr. Will Petchey, who had prepared this presentation. He's our fantastic clinical director in medicine, but unfortunately he isn't able to join us this evening. I'd like to express my own personal thanks as medical director for the extraordinary work Dr. Petchey has done in leading the physicians through such an incredibly difficult time during COVID, and also pay tribute to all the outstanding doctors that I'm so proud to work with and represent as their medical director. Dr. Petchey's reflections on COVID are really outlined in this talk and echo those of so many doctors, including myself, that I've spoken to and worked with during the first two waves of the pandemic and subsequently. As Liz mentioned earlier, it seems such a long time ago that COVID first reached our collective consciousness, initially through the news, as we watched the situation evolve in China and then in Europe. And as doctors, our initial encounter with COVID was really characterised by such a high degree of uncertainty and unknown quantities. We were dealing with something that felt completely unknown, with little understanding of the nature or scale of the pandemic that was going to unfold. In tandem with this, we had a change from our normal structures to what was called a command and control structure, and this was mandated by NHS England. And in this structure, decisions would land from NHS England for immediate implementation and often with little rationale to help us understand why those decisions have been taken. And in West Suffolk, this was really the calm before the storm. We adopted an emergency rota for doctors, cancelled all non-emergency work, and geared up for what was to come. Doctors were working night and day, 7 days a week, both in the intensive care unit and on our wards. We often felt powerless to treat patients at that point, because other than providing oxygen and supportive care, there were no more specific therapies available during that first wave. However, it soon became apparent that lockdown was effective at stemming the tide of COVID in that first wave, and we stepped down the emergency rota very quickly. Wave 2 was very different. Our ICU and medicine capacity was exceeded rapidly. The situation felt overwhelming at times, as ward after ward had to be converted to look after COVID patients. At one point, entire wards were being turned over to COVID every few days. Fears about PPE shortages only compounded the distress caused to staff, who described the psychological impact of dealing with so many sick patients. In December and January of last year, the staff rota, of early this year, the staff rota was being revised every morning as doctors themselves went down with COVID. And at times our doctors were doing ward rounds of 50 patients at a time, which was just completely exhausting. Coming in hours earlier than usual and staying late in the night just to get round and see the patients to keep them safe. Junior doctors and consultants alike were moved at short notice to unfamiliar wards and environments to help support COVID patients and learning new skills every day. This learning curve, it was vertical. There was an information overload, and when we looked at PubMed recently, last week, we discovered over 200,000 published articles relating to COVID. So you can imagine what it's like as a doctor trying to keep up to speed with all the latest developments. National and international and professional guidelines were landing almost on a daily basis at points. We learned much about the way that COVID could present, and that it's not just a cough or shortness of breath. Sometimes patients were coming in with confusion, with difficulty walking, with gastroenteritis symptoms, with cardiac problems and neurological problems, all of which turned out to be COVID. There are so many memories of that time. The supply shortages of tests, drugs, oxygen, face masks, PPE. The loss of autonomy that many doctors felt when a turn to a military command structure happened, and doctors felt that they weren't clear why certain decisions were coming down from the national team, and we weren't sure why they were happening. Doctors felt overwhelmed by the number of patients, and initially the fact that there were so few treatments available. We encountered so much isolation and loneliness that our patients were experiencing when their loved ones weren't able to attend them in hospital. And at times we saw patients dying without their loved ones next to them, with only their nurse or doctor present. We watched our own doctors, colleagues, friends, themselves succumbing to COVID. And in our intensive care unit, a small number of patients sadly succumbed to the illness. And this led to feelings of guilt that we couldn't save some patients from COVID, and also guilt if you yourself developed COVID and weren't able to work and help colleagues on the wards. And this was then compounded by the exhaustion of working in PPE all day, short-staffed and on a full rota. Looking back, there's so much to be immensely proud of at the West Suffolk. The fact that we consistently treated to international best practice, and when we audited our use of medication, 100% of patients received the appropriate medication at the appropriate time. The survival of our patients in the intensive care unit was considerably better than in many other parts of the country. We were early adopters of new and exciting treatments. For example, a treatment called tocilizumab, and we were one of the first centres to use this treatment outside of the intensive care unit. The camaraderie that we all experienced with everyone pulling together, doctors, nurses, pharmacists, therapists, everyone felt that we were in this together. I'm really proud of the clinical trials that we fully embraced. There are a number of them and I won't name them in detail, but these provided an opportunity for both our staff and patients to help change the face of COVID-19 treatment. I'm also really proud of the expansion of the clinical psychology service that the Trust took on to support staff through these truly exceptional times. And finally, I'm also proud of the fact that by working with our doctors on their well-being, we were able to publish our own experience and learning around doctor well-being in the Open British Medical Journal earlier this year. And finally, what about the future? We've learned so much about how to treat COVID. New treatments arriving regularly, including a new treatment that we have available only this week. We've talked about the virtual wards and Kate described those in detail. We continue to work as a system and collaborating with primary and community teams, again as outlined by Kate, and that's work that we need to continue to do. We need to continue to empower self-management of patients, patient self-care, self-monitoring, and the greater use of our patient portal where patients can access their own records. We also need to learn how we can effectively identify and treat long COVID, the fatigue element of which really cannot be underestimated. And then lastly, deal with the backlog of clinical work, especially delayed surgery, which Helen will discuss in more detail shortly. And finally, it's been my absolute privilege to work with such an outstanding, dedicated, highly skilled, caring and compassionate team of doctors, nurses, and a whole range of other clinicians. And I'm immensely proud to be part of such a fantastic team.
Thank you so much. Further evidence there, just how tough it's been during the pandemic, but how everyone has pulled together and once again changes which were born out of necessity will have a lasting impact on the way some of the services are delivered in the future. Now, finally, over to Helen Beck. She joined the Trust in 2014 and in 2017 became our Chief Operating Officer, and she's now also having the additional role of Interim Deputy Chief Executive. She's been instrumental in guiding the Trust through the pandemic, is now focusing on adapting and recovering services that, like everything else, were affected so dramatically over the past 18 months. Over to you, Helen.
One of us had to do that, didn't we? So thank you very much, Emma. One of my key roles is also board level responsibility for emergency planning and response. And you heard Paul talk about command and control, which is often used in emergency planning. When the NHS declared COVID to be a level 4 major incident, we suddenly found ourselves being very much commanded and controlled from the central teams, and we in the local hospitals were responding to that. I think the best way I can describe the beginning of the pandemic for us trying to work either clinically or operationally managed services was that we were absolutely in uncharted territory. We were learning as we went along and doing our best to deliver safe care to patients. There was definitely no roadmap that we could follow this time. We followed national guidance, but that changed almost daily as more and more information became known about the virus. It was a very uncertain and distressing time for all of us, as Paul and Kate have outlined. We cancelled all non-essential services within the hospital. And there were two main reasons for this at the beginning of the first wave of the pandemic. The first was that we were absolutely preparing to be overwhelmed by COVID demand. And you will recall some of those horrific images we saw on the news as waves of COVID hit other hospitals in the international community. We were also very clear we did not want to put patients at risk of contracting COVID in our hospitals. So bringing patients into hospital for elective procedures was really not felt to be in their best interests at the time. We needed to reduce the footfall through the hospital to reduce the risk of transmission, and that we therefore had to stop almost all visiting, which we know caused significant distress to patients, families and the staff. None of these decisions were ones that were taken lightly. But how did we therefore respond to these challenges and work to support both our staff, our patients and the community? Well, as a digitally advanced trust, we were well placed to start to respond to those challenges. Derek's colleagues in our amazing IT team set up the facility for virtual video consultation in every single clinic room in the outpatient department within the first couple of weeks of the pandemic. They also deployed a platform called Microsoft Teams. It's our equivalent of the Zoom calls I'm sure you've all had in your private life. They deployed that again across the whole organisation very, very rapidly to support people to work from home, avoid large gatherings on site, and enabled us to continue to function and deliver training. We were able to take advantage of these technologies as well as our fully integrated electronic patient record to set up a clinical helpline for relatives of patients in hospital using the clinical staff on in the trust who were shielding. Members of the public family were able to phone into the helpline and get updates on how their loved ones were doing and the care that they were receiving. And to date, the helpline has dealt with more than 40,000 calls. This service had great benefit to families and also supported the staff on our very busy wards, and I'm pleased to say has been established as a permanent service. Our teams also established a video conferencing facility to enable families and patients to keep in touch during this period when there was no visiting. This service clearly has no geographic boundaries and so has allowed visitors who would not normally be able to visit to also keep in touch. And we've had video calls arranged between Australia and New Zealand, to name but a couple of places. I'm delighted to say that the clinical helpline was shortlisted for a number of awards recently. They were shortlisted for the Patient Safety Team of the Year award by the Health Service Journal, and also in two categories for the Patient Experience Network Awards. The first being support for caregivers, friends and families, in which they won that award, and the second, the staff engagement and improving the staff experience, in which they were runners-up. We're really, really proud of that team and delighted that we're able to keep those things going. We also needed to step up our ability to swab patients, understand their COVID status and manage risk. Setting up the COVID swabbing service was actually one of the first things we did as a hospital. At this stage, the national strategy was to try to contain the virus, but as that became impossible overnight, the requirement changed to one of tracking the spread. We still do have the original swabbing pods outside of the emergency department, and they are still in use constantly throughout the day. But the service has grown beyond all recognition and looks to set to stay for the foreseeable future as COVID becomes endemic within our society. All patients who arrive in the emergency department now undergo a very rapid lateral flow test to now allow us to assess their risk and to stream people into the most appropriate clinical area. Patients requiring an emergency admission then have a rapid PCR test using a bank of Samba machines prior to allocating them to the appropriate ward area. Fun fact there, Samba is not a technical name. It relates to the fact that cartridges in the machines dance and appear to be doing the Samba. If you're scheduled to come into hospital for a planned elective admission, you will also need to be swabbed and you will be asked to self-isolate for 72 hours prior to your admission. We do realise how difficult this is now that everything has opened up, but case rates in our community are really, really high, and we do need to safeguard the vulnerable in our hospital. Infection control has been a key tenet of how we have responded to the hospital and was a significant challenge as we all learnt to deal with a new novel virus. I am sure you will recall all of the debates about how it was transmitted in the press. The same hands, face, space mantra that we were all encouraged to adopt in our personal lives was enforced within the hospital and continues to be the case. We've introduced social distancing in waiting areas, installed COVID curtains between patient bays in our ward areas. We have enhanced PPE, personal protective equipment for clinical staff, and enforced mask wearing for staff and for patients who can tolerate it. We have enhanced cleaning regimes and hand hygiene. And we also ask our staff to do lateral flow tests twice a week, and that is now set to continue. So where are we now in terms of COVID? In common with the rest of the NHS, we find ourselves with significantly longer waiting times for elective procedures, as well as a very high demand for urgent care and the need to work to COVID-safe procedures, which has reduced our flexibility and our efficiency. Overall, this means things are complex and do take longer. And in addition, on the West Suffolk site, we face the additional challenges of the remedial work programme, which Craig has alluded to earlier. We're making good progress to address this and are certainly ahead of the other affected hospitals. However, this has reduced our bed and theatre capacity in the short term and is impacting on the speed of which we can recover our elective waiting times. So it's quite clear that doing things as we've always done them will not address the future challenges. And the longer the situation continues, the worse the problem becomes. In terms of our outpatient transformation, we already had an existing programme of transformation that we were embedding, but COVID, like many things you've heard, has allowed us to accelerate that programme and to move forward to change the way in which we work. We've increased the number of virtual appointments we deliver, and going forward, the NHS has set a target for at least 20% of all NHS outpatient activity to be delivered by telephone or by video consultation. We've initiated a scheme known as patient-initiated follow-up. This means that suitable patients can arrange their follow-up appointments as and when they need them, rather than a predetermined time that we dictate. This makes better use of patient and clinician time and allows you to access the clinics when you need it. We're making much more use of NHS advice and guidance services to support your GP and enable the GPs to have access to clinical advice from our consultants. And we've also rolled out our patient portal. This is free to sign up to, and it gives you access to secure online systems and to look at your information, your hospital record, manage your appointment, receive test results, etc. You can find details of how to sign up on our website. All of the measures I've described there are designed to avoid people needing to come to hospital who do not need to, and in turn release capacity for those of us who do, and enable us to maintain social distancing in the outpatient environment. I do know that one of the things that people will be most interested in is how we are tackling our waiting lists. At the moment, we're prioritising the most clinically urgent, as determined by our clinicians, and the longest waiting patients. We're working across the integrated care system with our colleagues at Ipswich and Colchester, as well as independent sector providers at the Nuffield, the BMI and the Oaks. And we're trying to ensure equity of waiting times and offer patients earlier appointments in other locations where possible. So you may be contacted by one of our teams and offered a slot for your procedure in another organisation as we work more collaboratively together to reduce waiting times. We're offering pre-surgery services aimed at improving people's general health and fitness in order to protect them for their surgery, and we're working in an innovative partnership with Abbeycroft Leisure to provide this. The clinical helpline and the keeping in touch teams have been established, as I've said, moving forward, and the swabbing and pre-admission services are here for the foreseeable future so that we can manage flow of patients through the organisation. We're also recommissioning a previously mothballed theatre, which will come online in the new year and will give us an additional capacity to help us to work through those backlogs. And we're looking to develop an elective facility at Newmarket, subject to securing funding and planning permission to do that. In terms of emergency care in the A&E department, we've increased the capacity in the department. We've set up rapid testing to enable us to segregate patients and introduce red and green pathways to keep people safe and secure. And we continue to look at ways we can innovate and increase capacity to manage the incredibly challenging demand on the services that we provide. Thank you. On that note, I'll hand back to Emma.
Thank you so much, Helen, for that broad insight into how the trust has been affected across the board by the pandemic. And now it's time for some questions. We have, as is the way with these kind of things, overrun a bit. So we'll just have a few. And if it's not clear who's going to answer, Craig will decide. So the first one here is, we hear that accident and emergency is at the highest level of pressure ever. How is this being managed? And is this all COVID or because people can't see their doctor?
I think that's one for Helen initially, and maybe Paul.
Thank you, Craig. So I think it's multiple reasons why we're seeing that increased demand. I think our colleagues in primary care are also seeing increased demand. So I know there are some frustrations about people being unable to access a GP. I would like to say in support of our colleagues in primary care. They are fully open and they are working, but the demand on their services is incredibly high. We're also seeing patients who've delayed seeking help on occasion, and they are now requiring support as an emergency rather than in a planned way, as well as people who, due to the lockdown and the pandemic, some of our frailer elderly patients who've been unable to get out and about have what we call deconditioned. They've lost confidence and they've become more frail. So we are now again seeing an increase in COVID demand, but by no means is this the principal reason for the demand on our services at the moment.
Okay, thanks very much, Helen. Next one. How are you feeding back to government your very drastic staffing issues?
Thanks, Emma. I'll take that one. So it's clear from what Helen's just said and what you've heard during the presentations that we are seeing a significant increase of demand for services. As I said in my presentation, we deliver healthcare through people. And when the demand goes up, our need for people goes up. We share that at every opportunity, both within our integrated care system, so within colleagues at other organisations locally, but also with our regulators. It is the most common thing we talk about. We desperately need more staff.
Okay then, and do you support the idea that a significant pay rise for NHS staff will help with recruitment and retention and impact positively on staffing numbers, especially the nursing staff?
So I think it is very clear that over the period of austerity, that pay within the health service has not kept pace with the cost of living, and that will need addressing. And I recognise how difficult that is, but I think one of the things we've realised over the course of the pandemic is what's important within the communities that we live in. And those aren't always the people who are most highly paid. So whether that's supermarket workers or delivery drivers or healthcare workers, we probably need to reassess our priorities. So, and I know this is not necessarily a corporate line, but I would absolutely support a pay rise for NHS workers.
Okay, now just to wrap things up, I just need to reflect very positive words about Kate. So thank you so much, Kate, for your comprehensive picture of the community response to the pandemic. Very proud to have you on our team. That's from Jane Sharland. And also thank you for including Kate Foxwell to represent the community matrons and community teams. It's important to acknowledge the work that's carried out in the community. Well done, Kate. So a lot of love for you there, Kate. Thank you all for your questions. Now we'll hand back to Sheila, who will wrap things up this evening.
Thank you very much indeed, and thank you all. I think as speakers, you've been really thought-provoking, moving, and actually just what we needed and wanted to hear at the end of this difficult year. Special thanks to you, Paul, for stepping in at the last minute and standing in for Will. We really appreciate that. But it was that reflection on real people's experience, patients, staff, in the acute, in the community, how it was, which I think has been very special this evening. And I really thank you for sharing it in a very personal way. That's been important for us to hear. Emma, thank you for your professional input. You brought a touch of professionalism to the rest of us amateurs. We really appreciate that, so thank you. But I also want to say thanks in a wider sense. My non-executive colleagues aren't on screen tonight, but I know that they will be in the rooms, so to speak. And I do want to pay a very great thanks to them for the support they've given me. But my thanks too to the wider board members. It's been a very tough year to be a group as a board. Working in this virtual way is not the same as being in the same room. And I think we found that whether it be board or whether it be governors or anything else, there's a lot of sharing over tea and cake that really helps things move along. And we haven't had that opportunity. And I'm sure that those of you listening tonight, you found that in your private life. It's been a difficult year in so many ways, even if you weren't at the sharp end of all this. I do want to pay thanks to the communications team who've put this together. If it's not been an easy year for us, it's been a really tough year for them. They've supported us. They've made it possible for us to work. They've tried to make it possible for those of you who care deeply about the trust to be engaged and involved. And it's not always been easy. And we get very ratty when our technology doesn't work. And I don't care whether you're the most senior person in the room or, you know, you're somebody out in the sticks. It's very frustrating when things don't go according to plan with your IT. But the biggest thanks goes to you for being there, for attending. And I know many of you who are out there tonight will be people who regularly support the trust, whether it be as a governor, whether it be through the charity, or whether it be just through being one of our very valued patients that I hope we've managed to look after in the best possible way. And thank you for your thoughtful questions. They've been a great bunch of questions. It's been really helpful. And thank you for the positive feedback to the people. And you know, the feedback to Kate, that was lovely and well deserved. We must never forget the huge important role that community plays. And finally, I really look forward, we all look forward to seeing you face to face next year. It would be a sheer pleasure. And yes, there will be tea and cake. At this point, I would normally wish you a safe journey home. As it is, I'll wish you a good supper and a good rest of the evening. Thank you so much. So thank you to everybody for all you've done. And a special thanks to James and to Helen, who don't want to be acknowledged, but they have played a massive role in making sure this evening worked. So thank you. And as I say, safe journey to your kitchen. Good night.